A very good afternoon to everyone. I'll be talking about indications and contraindications of DSEC and case selection, especially for the beginners. We have no financial interest or relationships to disclose. The indications of DSEC basically include any kind of endothelial failure. The conditions which need DSEC are either isolated endothelial failure, such as Fuchs endothelial dystrophy, pseudophakic or aphakic bullous keratopathy, and ICE syndrome, recent graft failure post-penetrating keratoplasty, or any other cause of endothelial decompensation such as trauma. So all these patients are good candidates for DSEC. The most commonly performed conditions are Fuchs and pseudophakic bullous keratopathy. In case of Fuchs, the DSEC is indicated when there are central guttate changes, if there is corneal edema causing increase in the central corneal thickness, and if the patient has cataract, then combined procedure can be done. Experienced surgeons are doing DSEC even if the patients have vision of 612 or 618 and had mild guttate changes but are complaining of glares and halos because of the easy and fast visual recovery. Now when we see the contraindications of the procedure, they are corneal stromal opacification with good visual prognosis, subepithelial scarring and corneal ectasia. Because all these conditions, penetrating keratoplasty will be a better option. Silicone oil in anterior chamber, as in these patients practically the eye is unicameral, there is high incidence of graft dislocation and endothelial cell loss. When the CCT is more than 900 microns, which is of common occurrence in congenital hereditary endothelial dystrophies, because the depth of the anterior chamber is less and the visual prognosis is less. But when we see the contraindications for the beginners, the list is a little more extensive. The most important is phakic patient. The learning curve of DSEC basically includes the learning curve of donor insertion. By whichever technique the donor is inserted, either the taco or by Busin's glide, it is difficult and it takes practice to master this technique. So when we are doing this in phakic patient, there are high chance of damaging the anterior capsule or crystalline lens. So phakic patients should not be taken in the early cases. ICE, because of presence of pus, where again the anterior chamber is shallow, the atrophic iris can cause migration of air in the posterior chamber leading to pupillary block. Then aphakic bullous keratopathy, especially when the vitreous is in the anterior chamber, as also there is higher incidence of graft dislocation in aphakic bullous keratopathy. Then any kind of anterior segment disorganization or presence of anterior chamber intraocular lens or iris claw lens, as in these cases the anterior chamber depth is less and more manipulation occurs in early cases while donor insertion, which leads to higher endothelial cell loss and endothelial failure. The same is the case with glaucoma tubes and functioning blebs. So good indications for the beginners are uncomplicated pseudophakic bullous keratopathy, where there is no vitreous in the AC, the pupil is circular and regular, the anterior chamber is deep, there are no posterior synechiae, there are no anterior synechiae. The second being Fuchs dystrophy with cataract. The experienced cataract surgeon who is transforming from PK to DSEC can do a combined procedure either with SICS or phaco and endothelial keratoplasty, as this technique does not require any additional skill, provided the cornea is sufficiently clear to allow safe view for the cataract surgery. So in conclusion, when we choose patients wisely, DSEC is encouraging and rewarding. Thank you.